there might be a connection between medication use and heart issues.
It's a conversation about risk.
It's pretty well established that stimulants can have those side effects, but they did find something more.
If you were to repeat this study, how likely would you be to get these similar results?
So this is a factor in decision-making around your medication, even if you're not the one making that decision. Hello, everyone. Today we have a really special episode of the Research Recap because we are talking to Fred Hooven. So Fred lives in Massachusetts. He is a US professor of public health and has a PhD in epidemiology. He's worked in research, health policy, and healthcare administration for about 30 or more years. But he was also diagnosed with ADHD himself in his early 40s, and he's been treated with different stimulants, at least 3, and some non-stimulants during that time. And we'll get into why that's important in a minute. And we connected with Fred when he joined unconventional organizations. So he's been a client with us. He said he joined a number of years after he got diagnosed, but it's been really, really great to have him both as a client to learn these strategies and also to hear his knowledge. And that's what we're going to be getting into today. So welcome, Fred.
Thank you. I'm happy to be here.
Yeah, it's great to have you here. It's great to have you on this side of the podcast talking about this.
Yeah, it's very different, but it's going to be fun.
Yeah. So before we get into it, I do want to just state we're going to be talking a little bit about medication. We're going to be talking about cardiovascular health. We're going to be talking about some of the other risk factors for people who aren't on medication. So there's a whole lot of complexity in today's research. And so what we want to really do is we're not telling you or telling anybody what to do. We always say, check with your health professional. We are not physicians. What you decide to do is your decision. Whether you take medication, whether you don't, whether you do a combination is up to you. What we want to do is what we always do on these research recaps, which is provide you with information about the latest research, about what is out there, and try and help you make some informed decisions. So that's what we're going to do today. And I'm really, really excited to get into it. So the first paper we're going to look at is called Attention Deficit Hyperactivity Disorder Medications and the Long-Term Risk of Cardiovascular Diseases. So this paper is the original paper that kind of sparked this whole conversation we're having today. Fred brought it to us. It was really interesting. It was from 2023, the Journal of American Medical Association Psychiatry. And the objective of this paper is long-term ADHD medication use associated with increased cardiovascular risk, which is a big question, which is why it's really good that we have an epidemiologist with us today to talk about it. So Sarah, do you want to go through a little bit of what they did?
Absolutely. I also just want to say I'm really excited to finally be here having this conversation. It's been in the works. And yeah, these papers were a little bit different from the ones we're used to reading, so it was really helpful to sort of have someone be like, oh yeah, actually, that's just what this is. No big deal.
That's what exposure is. He was just explaining exposure before we came on.
Yeah. So this is going to be great. All right, let's get into it. So this paper used the Swedish Medical Registry, which is something that, I was familiar with. I was like, okay, cool, something to ground myself, with reading the rest of the paper. Their sample size from that was 278,000, roughly.
Wow.
Age 6 to 64. This paper was specifically looking at people who had an ADHD diagnosis between 2007 and 2020. And then they sort of looked at how people were prescribed medication from that point. I didn't totally understand how they even got their control group. Fred was lovely to give us some notes on that, but I'm going to let him go in a second. But it was called incidence density sampling. It basically just said in the paper that they assigned 5 controls without cardiovascular disease for every person who had, but everyone might be taking ADHD meds. So I was just a little bit confused, how they were a control. Take it away, Fred.
Yeah, take it away. Tell us a little bit about what happened.
Sure, I can explain that. A nested case control study means they have a cohort. So they have this big Swedish cohort of people who they can follow from some point in time because they have all their records, right?
Mm-hmm.
And they are looking at people in that cohort. They're dividing them into people who had a CVD outcome, cardiovascular disease outcome, and people who did not. The cases are people who had them, and the controls are people who did not. And then what they're looking to do is compare the ADHD medication use between those two groups. So very simplistically, if you have the same level of ADHD medication use in the cases and the controls, it wouldn't look like ADHD medication had anything to do with cardiovascular disease. It's a very simple way of explaining it. Incidence density sampling just means that it's kind of a fancy way
Mm-hmm.
of saying at the same time someone became a case, meaning somebody had a CVD event, was diagnosed with hypertension, whatever it was, at that same time, based on the records, they chose 5 controls, people who were free of disease at that time, to match with them.
Oh, so if I'm thinking about this, so let's say, heaven forbid, I have a cardiovascular incident. In that moment when I have that incident, because I'm in the study, they grab 5 people who have not had that incident and they're like, you guys are all in a study now. Is that what's happening?
Yes, except they don't know it because it's just all these medical record data, right?
Observational data.
Oh, gosh. The Swedish are amazing and slightly terrifying.
Yeah.
So wait a minute. Does this also mean that you could be a control and a case in the same study?
Oh, now that's really, as an epidemiologist, I should have checked out how they handle that. Different studies handle that differently.
Okay.
Limitations.
Yeah. Generally, you are a control and you could later become a case.
Wow. Epidemiology is wild.
But they're essentially looking at the time you had, but that's an issue. Yeah, that's an issue that and I know they had a way of dealing with that in the paper, and they did a lot of really cool stuff in this, and there's some of it that I've forgotten about. But up until that point, they hadn't developed cardiovascular disease. So they're comparing, what was their use of meds, if at all, to the people who were cases.
Interesting.
Wow.
And then in terms of the cardiovascular disease you could have, can you just go through, Fred, because you'll know all the names and things, some of the different diseases that they were, like what the different things are?
Yeah. No, I'm not a cardiology expert. I believe it was ischemic heart disease. I believe that includes MIs, heart attacks, cerebrovascular diseases, which includes stroke, hypertension, heart failure, arrhythmias, thromboembolic disease, arterial disease, which I took to mean arteriosclerosis, anything that has to do with the clogging of the arteries. And I don't remember what was it. They have this other category.
Other forms, yeah.
It just says other, yeah.
It's pretty broadly heart. So it's, anything to do with the heart. And I just wanted to say that because I think sometimes it can be hard to know what that means, So yeah, I think that's a lot of different things. And they also had some exclusion criteria. So if somebody left the country or they died or they had pre-existing CVD, so they didn't include it if they were pre-existing or less than 3 months of data. And then in terms of the medication, they had a lot of different kinds of medications. You want to go through what the kinds they were looking for were, Sarah?
Yeah, so they had stimulants and non-stimulants on the list. The really common ones, methylphenidate, amphetamine, dexamphetamine, lixtexamphetamine, and like the non-stimulants, atomoxetine and guanfacine. Those are really broadly probably going to be familiar to a lot of people listening to this.
Yeah. So was there anything else that we should add to the methods conversation before we talk about the results, Sarah?
We should probably just mention that they did try to control for some lifestyle factors, like by using place of birth, any like co-occurring diagnoses. Fred indicated here that they also controlled for obesity and diabetes. But yeah, obviously they're lacking in some of that lifestyle information, which they do list as a limitation of this study.
Which will come up.
Which is going to become like it's going to be like a broken record by the end of this episode.
Like, we don't know what they do when no one's watching, unfortunately. We cannot control.
They did some really cool stuff with the statistics. Like they tried to run the numbers 4 different ways just to see like if their results were going to be broadly the same, and spoilers, they were. So that's cool. I think. Yes.
Yeah.
Yeah, that's great.
Is, yeah. Yeah, definitely. I mean, the bravery of those people to do it and then put it publicly. There's a lot of people out there who do research who are like secretly they know if they ran the numbers differently, they might get a different result, but they don't.
I think what's important, what they didn't do is they didn't try to find a result by rerunning their data, try to get a result.
Exactly. That's my point. Yeah. They were really sticking to that null hypothesis, which we love. Hey, you listening to this podcast. If you like what we do and you want to hear more of it, there is one way to make sure that happens. Please go ahead, subscribe, and leave a 5-star review. We have been told 5-star reviews can help us to get seen by more people, which means more people are going to learn about ADHD strategies.
Just press the button. Just give us a 5-star review.
So in terms of the results, they mentioned that a lot of people were using ADHD meds during the follow-up. So they did have a lot of people to do this study with. So what did they find? Sarah, do you want to take us off, and then Fred, you can add to it?
Yeah, I'll get us started. So it looks like roughly 84% of both cases and controls were using ADHD meds during their sort of follow-up period. So yeah, this is just all a bunch of people who have ADHD. This part is not new knowledge, but essentially what they found is that longer cumulative duration of stimulant use is associated with an increased cardiovascular disease risk, particularly hypertension, which is like high blood pressure, and arterial disease. Now, there's lots of examples of that, but the most common ones that I popped out were like an aneurysm or Raynaud's.
Yeah.
So it's pretty well established that stimulants can have those side effects. But I mean, they did find something more. Like they added more context to that information. And I think for that explanation, we should really throw it off to Fred.
Definitely. Because I'm looking at some results here. Largest risk increase during the first 3 years of cumulative use. Tell us, Fred, what was going on here?
That's interesting. I don't know why they're seeing the largest increase in the first 3 years. It could be that, and I can't remember how they dealt with this, it could be that people are dropping out. So that if you make it 4 years, you're feeling better. I mean, I had benign heart palpitations when I was first taking stimulants. It really didn't have to do with the stimulants. It had to do with other stresses in my life. But I got lots of other tests, but I might have stopped because of that, so that the people you may be left with over the longer period of time are people at lower risk.
Interesting.
This also kind of, and maybe it's to discuss a little later, but it also brings up, I got screened before I took them. I don't know what happens in New Zealand and other countries, but I had an EKG done before I was put on them.
I know that in some places they do that. And yeah, I wouldn't be able to speak to whether that's the case for everyone. Sarah, do you know if that's the case? Have you heard of that?
So no one asked me to test my heart, but I would imagine that people with like more risk factors for heart stuff, age being a primary one, that might be why.
Yeah, that's a good point, actually.
Yeah, I'm going to the paper to see if they explain sort of what that's about. And they really just say that the restricted cubic spline model suggested a nonlinear association. So it's stats magic. They don't extremely endeavor to explain it.
So, Fred, what else did they find? Take us through some of these results, because they were really interesting.
Well, one thing that was interesting was up until the 3 to 5 years that there was a dose-response relationship. So there was an increase in risk for people taking meds relative to people not taking meds for cardiovascular disease. And, anytime you have a dose-response relationship, that adds to, in epidemiology, because we deal with a lot of studies that are not clinical trials, we have these criteria for causality. how close can you come to saying it's probably causal? When you see a dose response, that's one of those criteria. I would say that, I think I already mentioned this, but I would say that the fact that the heart rhythm issues are not, people weren't at increased risk for those, but they were at increased risk for things that do seem to be related to lifestyle. And I'm not aware that heart rhythm issues are related to lifestyle. That is a hint that there might be more confounding, which would be the effect of people on medication longer also being more at risk, even without medication, for cardiovascular disease.
So if I'm a person listening to this and I'm thinking, okay, this is interesting. Some of this I know, some of this I don't know. What should I be taking away from this paper?
Well, talk to your doctor, medical doctor.
That's the disclaimer of this whole episode.
Not someone like me who's never treated anyone other than taking a splinter out of my daughter's finger. But have a conversation with your doctor and think about the risk of, hopefully your doctor or medical provider will be talking to you about the risk of bad things that can happen because of your ADHD compared to the risk of cardiovascular disease. Because something that you really haven't talked about is just these numbers are about how much higher someone's risk is if they are on these meds versus someone who's not. It's not what is that risk overall? Like if it's very low, if it's only 1%, 2% or whatever, and your risk of a bad event because you're not treating your ADHD is higher, your doctor may try to nudge you towards treatment. So it's a conversation about risk.
Yeah. And that's interesting because this paper does find that there is a risk factor if you take ADHD medication for having heart struggles. Like you said, Sarah, that's not new. And that this dissipates over time depending on medications.
It remains stable. I should have wrote.
Yeah, it remains stable. So it's sort of like there's always a bit of a risk. Is there anything else you wanted to add to those results, Sarah?
No, we covered the results. I should just mention some of the limitations of this study. They didn't look at people with pre-existing cardiovascular disease. Like if you had a cardiovascular event before getting ADHD diagnosis, sorry, but they should be studied too. So future studies should include them. They could not prove causality. They listed that as a limitation. So maybe they tried.
Well, it would be really
better
hard
luck
to do.
next time. Yeah. Right. They also listed exposure misclassification, which comes up again. And that means people not taking their meds as prescribed. So this study, again, it's based on data that nobody's really confirming. It's just sort of they're making assumptions that because you have this prescription, you're taking it as the prescription is written. And
that is such a good point.
There's no way they could ever prove that.
Yeah.
This is the geeky epidemiology thing that if there is error in measuring how much, whether people are taking their meds, it's likely to bias towards a lower risk. It's likely to be, it's like it makes the picture more fuzzy. So could be higher, but then that confounding by lifestyle could mean it's actually lower. Once
again, we do not know what people do when they go home, but they probably don't do what they're supposed to do. It's very, especially with your ADHD, like, gosh, like the amount of people.
We just like forget to take them sometimes though. So like, sorry, scientists.
And there is a conflict of interest disclosure as well. So one author had done pharmaceutical work.
Just like some speaking arrangements. I enjoyed that they put it in there. It was also supported by just like a bunch of European grants. They just seemed like they just wanted to look at the picture.
Yeah, definitely. Okay, so moving on to a paper from this year, similar topic, long-term cardiovascular risk associated with the treatment of ADHD in adults. And what they wanted to do was, since more people are being treated for ADHD, they wanted to evaluate this associations between long-term use and cardiovascular outcomes, specifically on adults with longer follow-up periods. So again, that interest in, hey, we know there's something going on, there's a risk here, and they want to figure it out a little bit more. And this study was not Swedish, but it was Danish. So Sarah, do you want to take us through a little bit about what they did?
Yeah, super similar, like nationwide register system that they were looking at. So likewise, pretty large samples. So we were looking at adult patients who started treatment for their ADHD between 1998 and 2020. They got just over 73,000 people. Based on the population demographics of that person, they found a person without ADHD. It looks like they went for like a 2-to-1 ratio because they have 145,000.
Mm-hmm.
And actually don't remember if these are all stimulants or not.
I've got them here.
Does it say that they're all stimulants?
To categorize patients according to exposure, they use methylphenidate, 30 milligrams, atomoxetine, 80, lisdexamfetamine, 30, dexamphetamine, 15, and modafinil, 300.
So they did use pretty much all of them. Were they all stimulants, or were there other additional ones in there as well?
Atomoxetine is in there, and that's not a stimulant, right? Strattera.
Yes.
Maybe that's all of the medications that they offer as ADHD treatment in this country.
Denmark, I guess. They pretty much put all of the medications on the table, which is good because they were looking for the association with, hearts. We want everything there. They did have some exclusions.
Yeah, they excluded people with like neurological conditions. So like multiple sclerosis, narcolepsy. And then they also put off-label palliative purposes, which I was like, what? And it really just means like for end-of-life care, like to relieve the pain without like treating the thing.
Yeah. And then there was some grouped exposure. So Fred, do you want to take us through what they mean? They said that they grouped based on exposure to medication and they stopped after a follow-up period. Do you want to take us through a little bit what that piece means?
Yeah, so they created these exposure groups and they report the exposure groups as prior users, which I found interesting.
Mm-hmm.
Prior users, people who use less than one dose per day, people who use more than one or equal to dose per day. At least their main results are reported based on those groupings of exposure. Mm-hmm. Exposure meaning people on the medication versus not.
Yeah.
But they're comparing to prior users, which is interesting as opposed to never users. And maybe I missed something there, but I found that interesting.
Interesting. Yeah. So a slightly different way of doing it, but still very similar to the last one. And then in terms of their outcomes, they were looking for acute coronary syndrome, stroke, heart failure, and those kinds of things. And they also did follow-ups 1 year, 3 years, and 5 years post-treatment beginning because they were particularly looking for things that happened over a long period of time. So what did they find, Sarah?
So I was really surprised by how close the demographics were between the exposure groups. I guess that's just a product of the culture.
Yep.
So the easy thing that I can say is that there was no apparent association found with acute coronary syndrome, which was like heart attack.
Yeah.
But they did find an elevated 10-year absolute risk of stroke, heart failure, and composite outcome. But like the difference doesn't look that big to me. I mean, we're talking about from 1.7% to 2.1%.
Did they look at it in terms of a p-value? Did they say whether it was a significant?
Instead of p-values, they use confidence intervals. And what the confidence interval tells you, if it's a 95% confidence interval, they're saying I'm 95% confident that this interval would contain the actual value. So it could be as low as the bottom part of that or as high as the top.
Oh, so that's interesting because I know about, confidence intervals, but in psychology, they do usually just translate it into p-values to get the significance. So Fred, what was the confidence interval of these different things? So heart failure, stroke, do you know?
I do. And in my notes, I took those out because I thought those were
brilliant.
okay. But I have it right in front of me.
This was the paper that I really struggled to read like the body of some of it, because it was just like there was way too much punctuation going on and abbreviations, and there were like percentages. And I was like, no. And so I just went to the tables. So thank you for.
There's a lot going on in this paper. Yeah. But the confidence intervals, the important thing is they're fairly tight. So when they say the elevated, they're saying over 10 years, what's someone's risk of stroke if they're taking ADHD medications or if they were a prior user. And what they say here is 2.1% for the equal to or greater than 1 per day compared to the prior, which was 1.7%. And when they give you the 2.1% for the group of users of the medication, they give you a confidence interval that's 1.8 to 2.4. So that's pretty tight. They're not saying it could be as wide as 1 to 3.
And so when you say tight, do you mean, is that a good thing or a bad thing? Because when we think about it in terms of p-value, it's like if it's 0.01 significance, that means it's like a significant difference. What are they saying here?
You have to stop me on this because I love talking about this. So confidence, not many people do. A confidence interval, just think of if you have an estimate of something and your number is 5, and the confidence interval is, the 95% confidence interval is 4 to 6.
Mm-hmm.
That means you are 95% confident it's not going to be lower than 4 or higher than 6. Now, if you have an estimate of 5 and your confidence interval is 2 to 9,
mm-hmm.
That's, wow, it's not a very reliable estimate because it could be as low as 2. That's what I mean by tight. Yeah, we pretty much know it's in that range.
Okay. So what you're saying is that even though these differences weren't very big, so, it was 2.1% to 1.7%, these were significant differences in the research.
Right. And being significant doesn't tell a doctor how clinically significant it is. They have to figure that out based on their own assessment of the patient's risk and everything. It's telling, basically what it tells you, if you were to repeat this study a number of other times, how likely would you be to get these similar results?
We're sort of seeing here again in both of these papers, and I really appreciate you, Fred, breaking this down for us because it gets really complicated, but we're sort of seeing here in both cases, there is this conversation around, okay, there might be a connection between medication use and, heart issues, but, and this is a limitation of this paper as in the other paper, there is no information on lifestyle. So we don't necessarily know if these people were, the way that they're living their life is also a risk factor, and that's complicating the issue, which is important because I think it's worth mentioning to those of you who are listening that even if you don't read this research, the person who is prescribing your medication and making decisions, your doctor, should hopefully either be reading this research or talking to somebody else who's reading this research. So this is probably a factor in decision-making around your medication, even if you're not the one making that decision.
That's a great way to put it. And I do appreciate in this paper that they showed you the absolute risk. Like we're talking a 2.1% risk of stroke for people who are essentially the treatment group versus 1.7 for the other group, which they use prior treatment. And I think that was to make them as similar and comparable as possible because they had chosen treatment at some point. But those numbers, I think, would be helpful to a physician in going, here's the difference in the actual risk. And they could compare that to, what's the risk of not treating you?
Yeah, definitely. Sarah, do you want to take us through some of those limitations before we close off on the study and go to the next one? Because I am interested in the next one, because I think the next one really throws a wrench in everything. So I want to talk about that as well.
All I have listed here is that there's no information on lifestyle.
Yeah, I think that's pretty much it. There was no information on smoking, exercise, eating. There was also a ton of different disclosures of medication, AstraZeneca, a whole bunch of other people were.
Lots of pharmaceutical employees on this paper.
Which is always just worth mentioning.
Like speaking fees and grants and things, so pretty much most of them. It was great that they sort of listed all of that out, very plain to see though.
Yeah. We've got like BMS/Pfizer, Bayer, AstraZeneca, MSD.
We don't always see that.
All of the stuff. Yeah, it's good. It's good to see that. So yeah, once again, these studies, which makes sense, they are being at least partially connected to different pharmaceutical companies, which makes sense. They are looking at pharmaceuticals. Okay. Well, let's talk about the last paper, because I think the last paper, and again, this paper is from this year, so this is hot off the press. We are talking about information on, mortality in individuals with ADHD more generally. So the paper is called ADHD Pharmacotherapy and Mortality in Individuals with ADHD. And what they wanted to know is taking ADHD meds associated with reduced mortality risk among ADHDers? So looking at it more generally, and this paper was not from Denmark because it was from Sweden. So Sarah, do you want to tell us what they did?
So I'm just going to flag that we don't have the full text for this paper, but we couldn't not include it because the part that we do have is very descriptive. So I'll tell you about that. First of all, it uses like 5 citations. And when I looked at all of the things that it references, they're all gigantic, like meta-analysis and things like that. So I was like, okay, that's great. So this paper comes from the Swedish registry, the same as before. They're looking at people who were diagnosed between 2007 and 2018. Exposure in this case meant that someone started medication within 3 months of their diagnosis. And then they just I think they just had one follow-up period of 2 years. And then they looked at mortality in 3 different ways. So they were looking at all cause, natural cause, which is like a physical condition, or an unnatural cause, which is, accidental injury, suicide, and things like that. Yeah. So it looks like they just looked at a bunch of data and made a bunch of observations, but maybe Fred can tell me more.
This is another really fancy study out of Sweden. And they did something called a target trial emulation, which I won't even try to explain here. And I'm kind of hiding the fact that I don't know if I could explain it. But the idea of it was to make this study as somehow simulate a randomized control study, which, by the way, you just can't do for these kinds of things, especially because ADHD treatment exists. It's indicated. You don't deprive people of treatment and put them in a control group. So they tried to do that through this fancy methodology. And what I liked about this study is they were looking not just at cardiovascular disease, but the other thing that I hope doctors and other medical providers will be looking at, which is all-cause mortality.
Yeah, it's very cool.
Never mind the other things in your life that could be bad if things are bad because of ADHD. Yeah. But it looked to me like it was accidental deaths, accidents like car accidents and stuff like that, suicide. I can't remember if they talked about any information on drug use. We know we've seen that in other studies. But
yeah, it was interesting. And I think it's a really important paper to have. So I'm really glad that they looked into it. So what did they find, Sarah?
Out of 148,000 individuals with ADHD that they were tracking, 56.7% of them started meds within that time period. And the 2-year mortality risk was lower in the group who started treatment compared to the group who didn't start treatment. Now, I would assume since they printed it, that's a significant risk. I'm not sure. Can you put more context to those results, Fred?
Yeah. 2-year mortality risk was lower in the group that initiated treatment than in the group that did not.
Yeah. So it says there's a risk difference of negative 8.9 per 10,000 individuals. But what does that mean?
That's the difference. There was a risk in the people who initiated treatment of the mortality rate was 39 in 10,000. Yeah. The mortality rate in people who didn't initiate treatment was 48 in 10,000. And then what they do is tell you the difference between those numbers, the risk difference per 10,000, which is 8.9. And I'm surprised the confidence intervals there is fairly wide, probably because they didn't have a huge number of deaths because it was an under 65 population. So if you don't have a lot of events, you're going to have a wider confidence interval. But it would be considered statistically significant.
Interesting. So what you're saying there is that there is a statistically significant idea that medication, so taking ADHD meds, was correlated with lower all-cause mortality.
Yes.
Yeah. Which is interesting because it's in opposition to what we just saw in the other papers. Yeah. So if we take just cardiovascular health and we look at that, then it looks like, okay, maybe medication is something we should, again, everyone's an individual decision, but like maybe there's issues around that. But if we look at this paper and we look at all-cause mortality, now we're saying, oh, well, actually, if it helps you focus when you're driving and you need that to not have a car accident or something like that, then maybe it's a good idea. So the complexity of the medication conversation is really the topic of today's podcast. We are not giving you the answer, but we are giving you the complexity. You're welcome.
Yeah, I should also jump in to say that starting meds was associated with significantly lower rates of all-cause and unnatural cause mortality. And then the confidence intervals are much like closer together on those individually. But when they're just looking at like meds, yes, no, it was like, wow.
Yeah.
Oh, yeah. And I think before I was quoting just the unnatural cause mortality anyway. But one of the things they do in here is they do a lot of fancy stuff, again, that I won't even try to go into. And one reason they do that is because they're trying to control for the fact that people who decide to start meds might have lower risk of death to begin with. They're more responsible, healthier, able to do that. And the people who don't start meds are different already and are already higher risk. I think they did a pretty good job at trying to control for those factors.
Yeah, very, very cool. So, if we think about this podcast episode, and it's been so amazing to have you here, Fred, to talk about this sort of stuff. This has been kind of the kind of episode that I've wanted to do for a long time. What are your thoughts now that we've had this whole conversation? What are your takeaways from this, Fred?
Well, one takeaway is this kind of thing is hard to study. Like I said, you can't do a clinical trial for something like this. So one thing is, anytime you hear someone say, but it wasn't a clinical trial, you have to remember, yeah, but you can't do one. So we really need these big cohort studies can give us a lot of information. I think it really helps us to understand the risk trade-off. I think I said that already. I think that's a big takeaway, is that you always want to be talking to your physician about what's the risk if I do? What's the risk if I don't? There are very few medications we take that don't have some kind of risk. A lot of people take ibuprofen. I'd love to see the risk of adverse events for these meds compared to ibuprofen, which as you age really does have some risk of some adverse events. I think that's the takeaway, is to have that conversation.
Yeah. But it's been really great because we've wanted to talk about ADHD medication for a while now. We get that question a lot, but we're not doctors and neither are you, but we really needed to have you on, Fred, to be able to dive into the complexity, as you said, of these studies. They're not very easy to study, and our special interest is the brain, and they don't have a lot of brains in them. So there wasn't a lot to get into. So, but it's good. It's really good to do this. And for those of you who are listening, if you do like this episode, please let us know. Please send some love to Fred for going through this and finding these papers for us. And if you want us to do more of these kinds of episodes, please let us know as well, because I would love to have, maybe Fred back or have more people on who are sort of able to come along with us on these research recaps and add more context.
More experts to teach us things.
Yes, more experts. So
yeah, and you guys, I just have to say that I love listening to your podcast. Epidemiologists are pretty wonky about research, and you guys are a lot of fun to listen to. So, and you do a great job.
Thanks. I appreciate it.
Huge compliment. Yeah, thank you.
Awesome. Well, thanks, everybody. And we will see you again for another episode next week. Bye. Thank you for listening, everyone, and a big thank you to Adam for making us sound great and Anastasia for making us look great. We couldn't do it without you.
And if you're looking for any of the references to the papers that we discussed, head on over to our show notes page because I always bring the receipts.
Plus, if you want to find out more about us or any more deep diving into what we're doing, you can find us on Substack. That's where the community is. That's where we're chatting, and you can see all of the fun and exciting things that we are bringing to the table.
Thanks for being here.